All right. Well, good morning, everybody. My name is Dr. Katarzyna Ostrzenska, and it is my honor to introduce Professor Adam Ostrzenski as your speaker today. As you know, Professor Ostrzenski is a leader in the field of urogynecology. He strives to improve surgical outcomes by constantly challenging the status quo. He routinely, and sometimes even annoyingly to his peers, works relentlessly to better surgical techniques. He is an expert in the true meaning of the word. His deep knowledge of the female anatomy has made him the leading expert in female genital cosmetic surgeries, as well as stress urinary incontinence, which requires zero slings or meshes. It would be very difficult to find any published papers in the field of urogynecology that does not reference Professor Ostrzenski's work. His profound understanding of anatomy and physiology has led him to develop numerous surgical interventions which have impacted and improved outcomes in cosmetic plastic gynecology, corrective surgeries for patients who suffered complications from such surgeries, classic abdominal as well as vaginal, laparoscopic, and hysteroscopic surgery, and female stress urinary incontinence surgeries. Professor Ostrzenski has also made multiple anatomical discoveries which will challenge the anatomy books forever. His discoveries include the G-spot anatomy and the role of G-spot in the genesis of vaginal engorgement, the labia majora adipose sac anatomy, the clitoral infrafrenulum fascia, the urethral stabilizing mechanism. Professor Ostrzenski is a laureate of numerous domestic as well as international awards for his contributions to the advancement of gynecological surgeries. In short, Professor Ostrzenski has single-handedly made an enormous impact on the well-being of women all around the world. Please welcome Professor Adam Ostrzenski to the platform.
Thank you very much for your kind introduction. And I would like to expand my very warm welcome of the participants of today's meeting. And I have problem to share screen. Ahmed, could you take care of it? Also would like to tell you that I'm going to do my best to elaborate on the existing controversy between the original description of perineal body and a contemporary definition. I would like also very warmly welcome to our lecture professors who assigned to this lecture from many countries around the globe. And hopefully we are going to warn the participants that medical graphics content of anatomy and surgery will be presented. Also, would like to let you know that I do not have any conflict of interest to present this lecture, which is entitled The Perineal Body in Women Anatomy and New Surgery. The lecture objectives is to elaborate on perineal body and POPQ, the pelvic organ prolapse quantification. And in order to understand this, I need to present the anatomy, gross functional and topographic, as well as surgical anatomy. Education, resources, training, the perineal body site-specific defect, a new surgical intervention will be presented in this lecture. Why this topic is important? Having damage on the perineal body can lead to dyspareunia, urinary and fecal incontinence, can cause a sensation of wide and smooth vagina, as well as can cause the perineal, the pelvic organ prolapse quantification system not working properly, causes for this topic of perineal body damage or injury is number one, OB trauma, GYN, botched surgery, or misdiagnosis. The first person who described the perineal body anatomy and illustrated them was Professor McAllister from England. In 1889, he presented the book to public, which was entitled Human Anatomy. And during that time, they considered as a practical surgical advice from anatomy. We should discontinue today as well. He described that the perineal body is a firm connective tissue mass located between the posterior distal vaginal wall and anterior rectal wall in horizontal orientation. This one was original and has been confirmed. The gross anatomy verification and topography was presented by O and his colleague Kark. Histology was presented by Soga, and he determined that smooth muscle and innervated by autonomic nervous system. He published in 2007. In 2010, MRI anatomy verification was determined, and this is the part that clearly indicates that McAllister was correct in his description. I would like you to know the location of the perineal body and confusion that this group of researchers presented in scientific clinical articles. Those presentations brings the vestibular bulb that they call bulb of clitoris over the urethromeatus. This is my study that I published in 2020, depicted how the vestibular bulbs are distributed in female anatomy. And there is no way that this structure is going this direction. Therefore, for you as a surgeon, it's very important to know that location of perineal body will be in this area, okay? The vestibular bulbs is connected together with the perineal body. The internal anal sphincter is connected to this body, and levator ani is connected to this body. This is the location that is it. Also, lateral extension plays significant role in maintaining the topographical relationship between the vagina and the rectum. Therefore, this is very important information to keep in mind. Essentially, problems started in 1996 when Bob and his group presented their study on topographic presentation of the female perineal body. I marked this here on a pinkish color, perineal body, that you can appreciate that they ask you to measure vertically, and they brought the perineal body down to the perineum, which is not correct. The perineal body is located here. This one is wrong, and we have to see what we have. Then, from that period of time, students as well as residents and practitioners were taught that perineal body is outside vertical structure. However, the standard core textbook for the obstetrics and gynecology students during their rotation was established in collaboration with the American College of Obstetrics and Gynecology. Reviewing this book, there is no description of perineal body at all. Then the next step was, what is our education in this field for OBGYN resident, the future specialists in obstetrics and gynecology? Unfortunately, those books that is almost a religion book in obstetrics created the perineal body here, and perineal body is located here. Residency program is based upon the precise ACOG educational material. I reviewed 2 of them, and it's exactly the same location, vertical location of the perineal body. Educational material for surgeons, practitioners, all the books that are very, very authoritarian book in the United States. This Kistner Gynecology was published by Harvard University group, the Ostergaarder Urology, and all of them are doing the same. Here is the Linde operative gynecology, and perineal body was brought outside. That's what you know, that's what you practice, which is not exactly what you. The next one is gynecologic obstetrics and gynecologic obstetrics and related surgery. Still the same. An atlas of the book is presented that when you put finger into the female rectum, you will see that perineal body is external vertical organ. Education in the entire globe is based upon the university, because they start students, residents, and fellow, specifically in OBGYN, the urogynecology, maternal-fetal medicine, and residency program for the general obstetrician and gynecologist. Affiliated hospitals with the university has a little advantage because professors from this university will lecture here. Freestanding, they are essentially on their own. They can invite professors to provide the lecture. However, when you take a classical textbook that we review, the teaching will be the same, that perineal body is external organ. Medical fellowship in the United States is specifically designed to produce a fantastic lecture, and according to current knowledge, usually lasts 24 months, and they teach the highest and unique clinical or research training, significant work exposure, and great deal of responsibility. This is the highest training that someone can get. The International Society of Cosmetogynecology offers 2 weeks fellowship, and there is a problem because there is no formal accreditation. And second, in the United States, legal issue is significant problem. What I am meaning by the legal issue is that nobody outside of this particular state, even in the United States, you cannot practice, you cannot touch the patient by law. Then I don't know how is this done correctly. Then our business today is who is right, McAllister, or contemporary definition is correct of the perineal body. If I have controversy that modern description differs from original, I usually go to the prosectorium and start research on the perineal body and then introduce to surgery. This one is a presentation of the perineal body in horizontal orientation inside the vagina. I am pressing here on transverse perineal muscle to show you. Also, over here, you appreciate that defect is present here, and mucosa is showing. And upon dissection, you will see anterior surface, much different from the posterior, particularly in distribution of site-specific defects. Also on this photogram, you see the lateral extension that the perineal body offers too. The descriptive perineal body anatomy is the anterior fusion of the posterior distal vaginal muscular stratum. I would like to refresh your memory that in vagina, you have two separate muscular layers. The first layer is circular layer, and the second layer is longitudinal layer. And perineal body is fused with those two structures. Laterally, through the extension, the perineal body is attaching to the pubovaginalis muscle, internal anal sphincter muscle, and the dorsoperineal muscle. Also, superficial transverse perineal muscle attaches the structure to the ischiopubic rami bone. The posterior perineal body is essentially attached by extension from the rectovaginal fascia or the anorectal junction to the internal anal sphincter and rests on the rectovaginal fascia, known as a denovularis fascia. That's my study, that's my documentation. Location, if you close your eyes, will be 1/3 of the posterior distal vaginal wall, and upper half of the anterior rectal orientation is horizontal. There is no central tender of fascia, and the differences in insertion of the point does not differ in any. Okay. I have interruption. Is any question? Okay. The superficial transverse perineum muscle, which goes transversely from one side to another, is part that the perineal body insert. When you take a look on these two muscles, puborectalis and pubovaginalis muscle, that are creating genital hiatus. And in order to understand correctly genital hiatus, particularly for students and residents, I put my fingers in imitating genital hiatus. And here is imitation of urethra, vagina, the rectum. And this part is crucial, particularly when you try to do something with levator, and you call this levatoroplasty, then you will either, if you do laterally, then you will make this larger opening in the width, and when you stretch, then you are going to put compression on the organ inside. Also, perineum body inserts to the bulbocavernous muscle, posterior proximal skin of the perineum, the internal anal sphincter, and the dorsal perineal membrane. This organ, the perineal body, is well secure by connection to the bones. The pelvic bone and ischio cavernosus and ischio pubic is the area that is. I did the measurements of the perineal body, and the height is on the average 4.2 horizontally. This is standard deviation 1.6. Thickness is 1.2 to 1.8. Standard deviation 1.5. The width is 23 to 27 centimeter, and the average width is 2.8 centimeter with 0.5 standard deviation. The perineal body innervation has two sources. Muscular structure is innervated by by autonomous nervous system, means that you cannot control this nerve, and also gets branches, but they are not autonomous, from the deep perineal nerve and inferior rectal nerve. Damage to this nerve may cause some problem in the perineum. Also, when you do the perineal body imprint in adult woman, you will appreciate that this over here location is inside the vagina, and you can see the imprint of the perineal body. There is no question that it's horizontal orientation, not outside of the perineal body. And that's how does it look in adult woman. What is the most common cause for perineal body injury? By far is obstetrical surgical cause. The next one is surgical, gynecologic surgeries, reconstruction of this area by the modern technique that is getting popularity. Unfortunately, the tightening of the vagina by removing the distal posterior vaginal wall and removing perineal, partially removing superficial transverse perineal muscle and perineum is disaster. As you can see, this one is marketing picture from the International Society of Cosmetogynecology, and you see that the experienced surgeon already make holes inadvertently. This is new bleeding, as you appreciate. This will call for the perineal seal very shortly after the surgery. Also, this one was published in one of the books, how you remove, and you're removing vagina wall, the vaginal wall, and you are removing the perineum body. This one leads to significant problem. Urinary incontinence, fecal incontinence, dyspareunia, as I mentioned above. Let's take a look what I have in my practice. This is the patient that perineoplasty, as you can see, was done by the method that is offered in the teaching by the International Society of Cosmogynecology. Here, urine is leaking when patient is resting. You can appreciate. completely numbness of this area. And incontinence and numbness is the predominant symptoms. This one is significant headaches. I try to elevate the superficial transverse perineal muscle higher. That gives a little sensation during sex. The damage related to the urinary incontinence is much more difficult to treat, and you have to go and do something above the urethra in this area. This patient was documented by Johns Hopkins University, the MRI department, and as you can appreciate, is less than 1 centimeter. This structure is approximately, as you see, 4.2 on an average. That's how they say no question that they caused this patient urinary incontinence that she has never had before. My study documented that perineal body are located under the posterior distal vagina, and you see this defect here than you saw on the original picture that I show you before. I will refresh your memory. See this? This is exactly, but it's much more extended than clinical diagnosis can be made and verified by MRI, no question about it. And here is the perineal body. Taking messages home. What we learned today, number one, you ask yourself, what is it? What is the perineal body? A smooth muscle mass. Location, as you see here, is between the posterior distal vaginal and the anorectal structure. Is in horizontal orientation. And then the pelvic organ prolapse quantification needs to be revised due to the horizontal topographic location of the perineal body. This, the POP quantification that is popular and is requested by almost each university and each exam that you are taking, is wrong. Functional, what we learn about the functional? The perineal body function is not clearly defined. My study raised more scientific questions about the role of the perineal body in pelvic organ prolapse, the role in fecal incontinence, the role in urinary incontinence. And this problem has to be addressed to what extent resection can withhold the urinary and fecal incontinence. This is absolutely disastrous disease, and you do not have treatment for it. I try to organize, and I have a group right now that I am studying, but I cannot provide you definitive answer what to do with this. And of course, the pelvic organ prolapse prevention is as a part of function. Why? Because perineal body plays a critical role for maintaining the topographical relationship between vagina and the rectum. You remove this one, this part sooner or later will follow. Now we are going to the last segment of my lecture, new perineal body surgical intervention. When you have my anatomical description of the perineal body, and I am pleased to tell you that very first time in scientific publication, the perineal body was documented by photograms. And these photograms, you see how is this location presented. Second, of course, I put this perineal body on stretch. See the clamp here? I am stretching to see how far is this going, okay? And that's what I brought outside. It's not outside as this picture is, as this photo is showing, because I am stretching the distal, I am stretching the posterior distal vaginal wall. That's perineal body. This is the defect. That's what we are saying. That's what we are saying is going through and through. Those defects I observe very commonly when distal vaginal wall is prolapsing. That's what you call in all nomenclature the rectocele. The posterior rectocele is almost always present. Almost always the urinary incontinence is present. Almost always dyspareunia is present. Okay, the perineal body surgical anatomy. We went through it. I am just showing you how to open the vagina. The small incision must be made here. Then you can use scissors, separate, but I put the scissors on a purpose that you can see that the entire vaginal wall must be dissected from it. Then you continue dissection, you remove this part, and you see this mass protruding anteriorly and is connecting to those structures are extension. And here is posterior perineal body, many defects. And question from my study is necessary to repair all the defects? I did in this particular case, all the defects, or just major defects. But the study must be done to determine which one is right. The next one is to establish how this structure, when you put on tension, that you see that the defect is disappearing, but additional defect, very severe defect is present here. Then you have to do the scarification. You have to make those edges to bleed, bring, including inside, bring them together by suturing, and then restore the defect here by doing the same. You appreciate that perineal body doesn't have fascia, doesn't have any central tendon. And this one is important for you to remember. Thank you all for your attention. As I promised, this is again my website that you can utilize for educational material that I publish. Right now, I would like to instruct you that you can click on chat, which is at the bottom of your screen, next to the screen share, which is in green color. And you may send questions, comments, or whatever you like to do in reference to this lecture. Thank you again for your kindness and attention. And see you next. Lecture is going to be on December 15, the same 9 o'clock. This lecture, I was invited by Padua University School of Medicine to present together a lecture on perineal problem during labor and delivery. The speaker from Padua University will be represented by Professor Eric Cosmi, and I will do the part of new elements he is going to present what we are doing right now to hurt many women in reference to dyspareunia, fecal incontinence, urinary incontinence, widening of the vagina, opening of the vagina, gapping vagina, and I can go, you know, this stuff. Then as soon as we present this lecture, we will know what to do. Also, we are currently doing research on it at the Padua University with Professor Cosmi and Professor Anne Aprile. Professor Cosmi is a gynecologist. Professor Aprile is forensic medicine specialist, and she is going to do anatomy with us. That is for the next lecture. Webinar still is going to be free, and I would like to take this opportunity and thank you, Mr. Ahmed, for his kindness and providing you with this free lecture. I know that this is costly for him, but that's how he decided to do, and I do appreciate his effort. Thank you very much. I'm going to disconnect sharing screen. And is any question?
No question, only Professor Kadir Shai from UK. I want to thank you for your beautiful presentation.
Oh, you're very welcome, and I appreciate your kindness and few words. Then thank you very much, and see you next time, December 15, 9 o'clock of the United States Eastern Standard Time, and I believe in Europe will be 15 p.m., 15 Greenwich time. Thank you again for your attention, and see you soon next. Goodbye.